Good day, everyone. I'm Sir Franz, and this is our case analysis for asthma. Our case reads as follows. A 37-year-old man presents to your pharmacy with complaint of cough. The cough began 3 months prior to coming to your pharmacy, and it has become more annoying to the patient. The cough qualities are it's non-productive, it's worse at night, and after exercise. He has had a sedentary lifestyle, but recently started an exercise program where he notes that he has a much harder time with exertion. This includes jogging. He just runs out of breath earlier than he used to, and he coughs a great deal. He did not have any fever, blood-tinged sputum, or weight loss, and he denies any nasal congestion and headaches. He does not smoke, and he has no significant medical history. When examined by the doctor, his blood pressure is slightly elevated at 134 over 78, and lungs are clear to auscultation, except when he was forced to exhale, there is a note of a wheeze. A chest radiograph is also normal. So with this information, what are important? The age of the patient. We note that asthma more commonly presents in children and in young adult males. So this is an unusual case because the asthma patient presented at 37 years old already. It is also important to note of the time frame. The symptom of cough has been occurring for 3 months, and we can already classify this patient's cough as chronic cough. And there are a short list of possible etiologies or diseases that present with chronic cough, and one of it is asthma. And it is also important to note how these symptomatologies are affecting the patient's life. It has become more annoying, and it has limited the patient from becoming more healthy by preventing him from exercising. We also note that this patient's cough is non-productive. So most of the time, allergic cough, which is um, the nature of asthma, presents as a non-productive cough, which means that there is little to no sputum production. It is also worse at night, and that is usual because at night, when the patient is enclosed in his room and is exposed to possible allergens at home, that is the time that the cough will occur. And after exercise, patients with asthma often have exercise-induced cough or exercise-induced asthma, where the rapid entry of air, cold air in particular, will trigger an allergic response or some sort of bronchospasm. It is also important to note that this patient did not have fever, which may tell us of an infectious process, any blood-tinged sputum, which may tell us again of an infectious process, or the occurrence of malignancy. Take note that this patient has chronic cough and is a little bit old, so we have to think of cancer. But this patient did not have any fever, blood-tinged sputum, or weight loss. The three, together with chronic cough, may point to tuberculosis, especially us here in the Philippines where tuberculosis is rampant. So he did not present with these symptoms, and we may be thinking tuberculosis is less likely. He denies nasal congestion and headaches. Another possible etiology of chronic cough is post-nasal drip, where instead of mucus secretion or um, nasal discharge coming out of the patient anteriorly, it goes out posteriorly through the choana and irritates the patient's respiratory tract, leading to cough. So because this patient did not have any nasal congestion, that etiology is less likely. He does not smoke, which is an important risk factor for chronic obstructive pulmonary disease and malignancy, which also presents with chronic cough. When examined, this patient has pre-hypertension, 134 over 78 millimeters mercury. And that can be a confounding factor because if, for example, the physician prescribes a beta blocker to this patient for the treatment of his hypertension and he also has asthma, then that can be a drug to disease interaction. All of the physical examination were unremarkable except for occasional expiratory wheeze. And this points to asthma, where because of the process of asthma, where there is mucus and decrease in the luminal size of the bronchioles, during expiration, there is some sort of a musical sound, which is the wheeze. So this points to asthma. Most of the time, patients with asthma, when they are not having an attack, will be unremarkable. It is as if they have they appear normal. So that is why when this patient went to the doctor and the chest radiograph is also read as normal, that is because he's minimally symptomatic already, not in an acute attack. So we have in this slide the pathogenesis of asthma. Let's look first at the normal airway. So if you take a section and look at it under the microscope, the airways at the level of the small bronchi will present this way. You have here where the air travels, and the wall, first you will encounter a layer of mucus, and that's normal. Then the goblet cell, which produces the mucus. And you have here the respiratory epithelium. This is pseudostratified columnar ciliated epithelium. And the normal function of this is your mucociliary apparatus, where the mucus is continually beaten um, away from the distal portions of the airway and into the mouth, so that mucus is constantly being expelled. So you have here the basement membrane, and you have smooth muscle. Then you have glands, and finally the cartilage. Comparing this to a patient with asthma, you first note that the mucus layer is very thick, and embedded in that mucus layer is an eosinophil, a type of white blood cell that is predominant in allergy. So you also see that the respiratory epithelium, particularly the pseudostratified cells, have abnormal morphology or it looks abnormal compared to the normal cells. And you have a thickened basement membrane, and you have chronic inflammation occurring in the lamina propria. So think of it this way: asthma is chronic inflammation of the airway, and that inflammation is particularly allergic inflammation. So you have hypertrophy and hyperplasia of the smooth muscle. So ibig sabihin, the airways of patients with asthma have a lot of muscle in them compared to the normal airway. And once they are triggered by an allergen, the airway of a patient with asthma, because it has lots of muscle, will contract very strongly, and it will constrict the airway very efficiently, leading to difficulty of breathing. You have hypertrophy of the glands. So you have lots of glands producing mucus, and in effect, you'll have a thickened mucus layer. Looking at it on a cellular basis, what happens? Next, you have triggering of asthma. What happens at the initial encounter with an allergen? You have here the pollen, and particularly a part of that would be allergen. And you can have lots of allergen, not only pollen, no? Even dust cells, even cockroach material, or even dander from dogs or cats or rats, no? So this will be processed by the dendritic cell, which is an antigen presenting cell. And that dendritic cell will tell the T helper cell type 2 to activate inflammation, particularly allergic inflammation. So your type 2 helper T cell will stimulate inflammation, and that is through releasing interleukin 4. Your interleukin 4 will then facilitate the conversion of B lymphocytes into plasma cells, which will start to produce immunoglobulin E. These immunoglobulin E will then attach themselves into the mast cell, and that will then prime the mast cell to rapidly release histamine and other inflammatory mediators at the next encounter. So your mast cell together with helper T cell will also produce interleukin 5, which will cause the eosinophil to go into the airway, from the blood into the airway. So that is the priming process. What happens during further or future encounters with the allergen? You will have here your allergen, and that is in the form of whatever you are sensitized to, whatever the asthma patient is sensitized to. Whenever that allergen comes in, it then activates your vagus nerve or your cranial nerve 10, which is present in the lung. Okay? And that will then lead to a reflex. So you have an afferent, so going into the brain centers, and you have an efferent vagal tone, which will then release acetylcholine here in the smooth muscle, causing rapid bronchoconstriction. The mast cell will also then release AUC, also then release serotonin, it will release histamine, and it will release other mediators that will then cause rapid release of mucus, and will also cause further constriction of the bronchial airways. And that will prevent air from going out of the lungs. Initially, it is easier for air to go into the lungs because inspiration or inhalation is an active process. But expiration or exhalation is a passive process. It does not rely on muscles. So during expiration, and you have thick mucus in the airway, you have a bronchoconstricted airway, expiration will be more difficult, and that will lead to air being trapped in the alveoli. So that is the pathophysiology of asthma. Together with symptom control, we use severity to help us decide how to treat our patients. And this is your GINA guideline. If your patient is able to purchase the medications, then we use this one on top. But if the patients have a hard time buying the medications, which is common for us here in the Philippines, we can use this regimen in the bottom. But for me, I always tell the patients that if they adhere to the regimen, the overall cost will still be lower compared to them returning again and again to the emergency room and being admitted because of uncontrolled asthma. So that will incur a really high cost, no? Compared to daily religious adherence to the controller regimen. So at the base of our therapy is, as needed, low dose inhaled corticosteroid formoterol. Formoterol is a rapidly acting but at the same time long-acting beta-2 agonist. Okay? So we combine that with an inhaled corticosteroid. The inhaled corticosteroid and even the formoterol itself will have anti-inflammatory activity. But of course, we don't use the beta-2 agonist alone because that will lead to tachyphylaxis. Remember the concept that if you give your ligand continuously, the receptor will downregulate and you will have to increase the dose to produce the same effect. So if that is the case, then continuous intake of formoterol will lead to lower effect of formoterol later on. So the goal here is really to give the inhaled corticosteroid as a controller so that you don't need your beta-2 agonist because you don't have acute attacks. Okay, so that is the main principle. But if you compare the past GINA guidelines, to achieve that goal, you would have a difficult regimen. No? Iba yung corticosteroid, iba yung beta-2 agonist. But what they found out through continuous clinical trials is that it is really safe to give at the outset, initially, inhaled corticosteroid combined with your beta-2 agonist. So for steps 1 and 2, where you have mild, persistent asthma, you can give as needed only when you have an attack, inhaled corticosteroid formoterol. If you have moderately persistent asthma, you can start your low-dose maintenance inhaled corticosteroid formoterol, which means 1 to 2 puffs every day. Step 4, medium dose, 2 to 4 puffs every day. And step 5, 4 puffs, more than 4 puffs every day. And we already give immunologic therapy here, where we give antibodies that bind to immunoglobulin E and antibodies that bind to interleukin-5. An example of that would be omalizumab, okay, which is a monoclonal body specific for immunoglobulin E. So then we consider high dose already of ICS formoterol. But the current medications that contain ICS formoterol, the brand is a little bit expensive. That's why we have this alternative regimen. So you have as needed at the base of the pyramid, as needed beta-2 agonist. Then step 1, take ICS every time you take a short-acting beta-2 agonist. Why? Because of tachyphylaxis. And that tachyphylaxis will worsen the bronchoconstriction. And eventually, if you use your beta-2 agonist alone, it leads to higher mortality. Low dose maintenance ICS, that's for step 2. So compare it. For steps 1 and 2 of the therapy above here, combined yung ICS and formoterol. But here, for our economic alternative therapy, you have, for step 2, only low-dose maintenance ICS. Step 3, low-dose combination of ICS, LABA, long-acting beta-2 agonist. Step 4, medium to high dose. And step 5, you have immunologic therapy. And lastly, I'd like to touch on status asthmaticus. Status asthmaticus is a medical emergency. You may encounter patients in your botica, outpatient pharmacy, who are in status asthmaticus. So you need to at least be aware of this. So status asthmaticus, medical emergency. It's an extreme form of exacerbation, and the patient will have low oxygen in the blood, high carbon dioxide in the blood, and eventually respiratory failure. So all patients with bronchial asthma, take note of this, all patients with asthma are at risk of developing an acute episode with a progressive severity. So this is your status asthmaticus, that is poorly responsive to standard therapeutic measures, regardless of disease severity or phenotypic variant. And this is from StatMed, okay? Or that's a website in NCBI. So you have to take note, if you have a patient who is asthmatic, that patient, even if the risk is very little, will still have a risk of having status asthmaticus. So if the patient comes in to your pharmacy, kulay blue, cyanotic na siya, really in respiratory distress, the first thing that you can do is, if you have a nebulizer there, plug in the salbutamol, nebulize the patient, and then call for help. Okay? So, eventually you have to send the patient to the emergency room. But if you don't act quickly, these patients with status asthmaticus can die. Okay? So you have to be aware of that. Status asthmaticus, think salbutamol nebulization. If they have no air entry already, epinephrine. You can give epinephrine intramuscular. So that's it. Thank you for listening to our case analysis.